Perfect.
Welcome,
Okay.
everybody. Oh, sorry, Lucia. Welcome, everybody. I'd like to thank Dr. Ma for joining us again today. She is one of the few people in our province who has expertise in hypermobile EDS. And so I will let her introduce herself and take it over.
Yeah, thank you so much for having me again. Yeah, so I do see we already have some questions, and we will get to those, and hopefully some of them are answered throughout the presentation. But yeah, just a little bit about myself. I'm Dr. Lucia Ma. I generally operate as a primary care physician, but for various reasons, I am also really focusing on hypermobile Ehlers-Danlos, among other hypermobility, genetic hypermobile disorders. The hypermobile EDS and hypermobile spectrum disorders are the most common. So I think that this will apply to most people. So the point of this one is, or the objective of the talk is to expand everyone's knowledge of hypermobile disorders in general, give a brief overview of the subtypes, and really kind of dive a bit more into the hypermobile Ehlers-Danlos disorder. And it's important to note that a lot of hypermobile spectrum disorders with systemic symptoms will have a significant amount of overlap here. So it covers a broad range of symptoms. And we'll talk about the diagnoses and the symptoms, and most of it is focused on the symptoms. And the resources, these slides are a little old, so there are a few more, but they're pretty similar. So I don't have any disclosures of interest. I do love this little meme. Oh my God, your skin is so soft. What's your secret? So anyway, so moving forward, joint hypermobility is basically a very, very broad term that encompasses many conditions. Now, it's a very broad range. You have everything from asymptomatic, generalized joint hypermobility, in which case people are very flexible, but they don't have any systemic symptoms or any symptoms. You have the other ones, asymptomatic peripheral, that's your elbows and your knees generally, and asymptomatic local. So LGH is singular or very focused joints that are hypermobile, but not enough. Your Brighton score would be negative, so not enough to be classified as generally hypermobile. And then every single one has a different subtype. So any of the hypermobile spectrum disorders, generally there's hypermobility, and often there are symptoms involved. So the chart helps it out there. And this is kind of what I mean, that in hypermobile spectrum disorders, especially generalized, you do tend to have some systemic manifestations, but it's not as almost predictable, I guess is a good way to put it, in some of the different subtypes of hypermobility. So if you only have local joint hypermobility, that ends up working out really well for you, because you probably won't have as many systemic manifestations of it. Now, this is the big umbrella term for all hypermobile individuals. So regardless of the genetic reasons why you might have it, these are often the most common places that symptoms manifest. So that's a nice graphic to help describe that. Now on to Ehlers-Danlos. This is the most common genetic condition that causes joint hypermobility, generalized joint hypermobility. There's 13 subtypes. Many people in kind of the Ehlers-Danlos and hypermobility world will basically put hypermobile spectrum disorder as almost the unofficial 14th subtype. But for academic purposes, it's still 13. And these are just the AD beside it means autosomal dominant. If it's AR, it means recessive. So some of them can skip generations, and other ones, it's very strong prevalence throughout families. And the most common one, and the one we will be talking about, is hypermobile Ehlers-Danlos, or hEDS. And they're working on genetic locuses for it. I suspect there will be more than one when we find out. Now, hypermobile EDS, since we do not have a genetic locus, unfortunately, yet, as I said, somebody with hypermobile EDS is actually currently working on that. Right now, the diagnosis remains only to be a clinical diagnosis. So though many of you, I recognize some names, many of you have kind of gone through my process of how I help identify this, but we rule out the abnormal subtypes and the other possible genetic causes through asking a series of questions and reviewing the history. And then we use other clinical questions and exams to help diagnose it. So the other part of it, which is in my second point, is that many unresolved or like genetic defects that are found that are outside of the ones in the 13 subtypes will end up being put into hypermobile EDS as well. So it ends up being an umbrella term as well. This is almost 80 to 90% of all EDS cases, and hypermobile people are often hypermobile EDS. The prevalence, I think, is probably a bit off, and many people have joked about that, but 1 in 5,000 is definitely not consistent with the number of people I've seen in BC, at least. Probably closer to the 20 in 1,000, which is more like 1 in 500. But I suspect it's actually probably more common than that, especially if you include the asymptomatic types. And as some papers propose, it is probably one of the most common systemic inherited connective tissues in humans. It's the wide spectrum. I've alluded to it. Some people, I met a 79-year-old who had all of the criteria of hypermobile EDS, and she had no symptoms whatsoever other than that she was hypermobile. So it can be done, and it does happen. But then there are a lot of people, and I usually end up seeing these patients more frequently, who have many symptoms. And it is dominant, so it is often in every generation. In a perfect world, genetic testing should be available to rule out other forms of Ehlers-Danlos and other genetic syndromes that can cause it, but it is becoming very evidence-based that if there's absolutely no reason or no concerns, or I guess you could call them red flags, that it is quite safe to not do any genetic testing. But I have quite a long checklist of things people have to say no to before we say that that's safe. So this is the 2017 criteria, and we'll go through that a bit more. I do notice there are quite a few questions, but we have a lot of question slides, so I'm going to ask you guys to bear with me until we get to those. So the Beighton score, passive opposition of the thumb to the forearm, the pinkies on both sides, the pinkies to 90 on both sides, the elbows extending beyond 10 degrees, and that most of us refer to as hyperextension. It is a common, I don't want to call it mistake, but it's a common misconception that the elbow and knees, which need 10 degrees or more of extension, that can be done visually. I can state with a fair bit of certainty that you really do need a goniometer. You need to measure the angle in order to see if you have the elbow or the knee extending beyond 10 degrees, but I haven't met many people who can eyeball that, and there some of the geneticists who do the talks for the EDS Society website will happily admit that they can't eyeball it, and they do it all day long. So it does really need to get measured. And then if you can place your palms on the floor when you're bending forward without bending your knees, then that's the final point. And then it's important to note you don't need all of them. When you're When you're in adolescence or a child, 6 or more is a positive general hypermobility score. 5 or more once you're basically through puberty, and 4 or more if you're over the age of 50, due to the fact that often over the age of 50, there have been injuries, there have been some osteoarthritis, there might have been some surgeries, especially with generalized hypermobility. And then it's not on here, but there, especially for anyone who's an adult, you do get an extra point if there are some of these things that you were able to do before, and like when you were younger, and there's a list of 5 other questions for that. If you get 2 more of them, like if you say yes to 2 or more of them, then you get the extra point. Yes, so this is criteria 2, and there's 3 sections to it. You can see those here. The skin features quite heavily, velvety, soft skin, the skin being mildly hyperextensible. That is 1 or more centimeters. And it does depend on which study you look at, but 4 or more centimeters is severe hyperextensibility. So we're looking for less than 4 and more than 1 centimeter. And you guys can all read those, but long and short of it, if you get 5 or more of feature A, if you do have a positive history, now many will say that it needs to be someone who has been diagnosed as hEDS. So many of us won't take the full check mark off, but many of us will write, or at least I will write, that there is a family history of hypermobility and whatnot, because in generations previous, people just weren't diagnosed. And then feature C is at least 1 of basically various forms of pain or joint instability. And then criteria 3 is your due diligence, is making sure you don't have any other types of EDS, any of the other 13 subtypes. The second one is to rule out rheumatological or autoimmune conditions that can cause connective tissue disorders. However, it is important, and it says it even there, that you can have both. So if that is the case, you want to have all 3, feature A, B, and C, instead of 2 out of 3. And then the last one is, and I alluded to that in the beginning, is there's a pretty long list of things I ask people to make sure they don't have any other reasons. So now we'll get to the questions. And for all of those who said hello, it's nice to see you too. First question is, how does knowing someone have EDS change the treatment of ME, CFS, MCAS, or POTS? That's an excellent question. I'm not sure that it would directly change. I think it would be more that the strategies one would use and might be different with someone with hypermobility and all of those. And also the fact that with hypermobility, you probably have an intersection of all of those at once. So I usually like trying to treat the MCAS first, because it does have trickle-down effects to the CFS and the POTS sometimes, not always. And then the POTS, and then seeing if there's an improvement in the ME-CFS. And if there is, that's fantastic. Even 1 extra usable hour per day is fantastic. It's a very, I'm trying to summarize this in a succinct way. It's kind of you kind of try to do a lot of things at once, but still in a way that doesn't overwhelm the system. And the reason why that changes is because if you have ME-CFS and you do too many changes at once, you can really flare up the ME-CFS. So I guess that's my best way of answering it. I don't know that you would do that any differently in someone who wasn't hypermobile and had all 3 of those things. So I see all 3 of those things, people with EDS more commonly. Yes, to my knowledge, Bruno will be sending the deck afterwards. Is there, yes, I'm generally seeing people through TELUS MyCare right now. And yes, there is no gene yet. It's being peer reviewed. So there's one that is potentially identified, is currently being reviewed. So that's exciting. Do people with hEDS take longer to heal from surgeries, especially knee or other injuries? Generally speaking, yes, with surgeries because of the scarring and healing that way, but it still can be done. And often with musculoskeletal injuries, if the hypermobility of the joints is part of why the injury happened in the first place, yes. Especially in ones that are very ligament heavy. So like the sacroiliac crest and whatnot, that's very, very ligament heavy. And sometimes things such as prolotherapy are very helpful for that. Any insights into folate levels related to pain from hEDS or hypermobility spectrum disorder? Vitamin D testing. It's generally understood that vitamin D in this part of the world is probably going to be low. So I do usually recommend people supplement it in general, primary care or hypermobility. In terms of the folate, I have just been made aware of those studies, so I'll take a look at them. I like people to eating or supplementing folate and B12, generally speaking. It won't hurt. That's generally, I just don't know if it's going to make a substantial difference in pain. But again, I haven't read the most recent study on it. Do I order genetic testing for hEDS? So in terms of genetic testing for hEDS, there's private and public. The public, they generally will only accept applications for out-of-province testing or out-of-country testing from a geneticist or a specialist. So they won't accept it from me, but I have ordered private ones before if that is something that people have covered or have access to. Benefit of being is there a benefit of being diagnosed and identified treatments? That's a loaded question, very loaded question. I don't know if I can answer that perfectly. Most of the people who have looked for a diagnosis and worked with me do find it beneficial. I find it beneficial because it gives me a roadmap of what generally will work for a person and what directions to focus on. So I'd say that's the main benefit. And identified treatments, I mean, we're kind of covering that throughout this talk, so I'll put a pin in that, but feel free to ask again if I don't answer it sufficiently. Soft skin is part of EDS. Yes, that is the meme. Very, very soft, velvety, doughy skin. And yes, there's a comment on the Beighton score, and yes, there are geneticists, among other experts, who will all acknowledge that the Beighton score is not the absolute ideal way. It's just the only, how would I put it? It's the only peer-reviewed, consistent way we have at the moment, but that we'd all like to have something a bit better. And reassessment is possible, I guess is what I'll say on that one. The slides will be available. And I think I'm just mindful of the time, so I'm going to keep moving forward. But the ones that I have answered, I'll mark as answered, and then I'll keep answering them. I like to have more time at the end so that we can answer as many as possible. Okay, so this slide is overwhelming, but these are very common and system-wide conditions that one can have with hypermobile EDS. So one of the things in primary care that I look for when I'm talking to people is I look for these. I look for these kinds of conditions that are present, and then I start asking about flexibility and hypermobility and so on and so forth. So it's very common to have the most common thing that put people on the radar are the number of dislocations, orthopedic exams, sports med exams, so on and so forth. But then I've asked anyone with POTS or dysautonomia, especially if they've already been diagnosed with those, about flexibility, and it's very common. Complicated allergic reactions in multiple systems. Headaches are huge, including migraines, and tension headaches. One of the things in the neurological that's not always well understood is that one's sense of one's position, proprioception, is the sense that one has within one's body of their position. And so that is actually decreased in a lot of people with hypermobile EDS and all EDSs. Possibly multiple different types of mobile genetic disorders, but definitely in this one. Usually most people are nearsighted with hEDS. Lots of gastrointestinal concerns, most commonly reflux because the sphincter is very loose. IBS, that's kind of multifactorial. It can be towards constipation or towards diarrhea. A lot of people have both. Crohn's disease has been increased, and possibly ulcerative colitis. So I'd say just IBD in general. In the more pelvic or reproductive symptoms, their painful, heavy periods are very common. Overactive bladder. There are more studies on males with hypermobile EDS, and they may be more prone to prostate hyperplasia. So that work's ongoing. It's very, very common to have TMJ. TMJ is often the joint itself is hypermobile, and the muscles often will overcompensate, but there's a lot more to that one. People have done entire talks dedicated to that. Dental crowding is one of the criteria. Eczema in the skin, eczema, scarring, as we've kind of mentioned, is very, it's not as bad as the classic or classic-like, but it's pretty significant. Acne in some people, and the acne scarring, and some people do get psoriasis. They're obstetrical, like sometimes there are obstetrical complications, and other times people have very, very straightforward experiences there. So that's, again, more research is needed. As I mentioned before, there are rheumatological conditions that are associated with hEDS, and then neurodiversity in general, along with other neurocognitive disorders, and definitely a lot of central sensitization syndromes. Yes, so this is one of my favorite cartoons, if you will, but the fable of the numerous blind men trying to describe an elephant to each other. I feel, as many do, that especially in medicine, it's very hard sometimes for people to step back from all the different specialties, and instead everyone will hyper-focus on their area. And this is what happens a lot. And in multisystemic diseases like Ehlers-Danlos, it's not always as helpful unless there's someone who can help oversee and direct it all. Yeah, and we're going to do that. So on the musculoskeletal side of it, it's the side that most people have focused on for the longest amount of time. There was a long time where a lot of specialists thought that this was pretty much the only thing associated with hypermobility. So in childhood, or they go through 3 phases. In the childhood side, they call it the contortionist phase, where you can pretty painlessly, literally contort. They call it the second phase, the pain phase. So 20s to 40s or 50s, where if you are going to experience pain and get symptoms of that, then it all kind of arises in adulthood. And then the stiffening phase, where if you do end up with, and most of the time you do because of the hypermobility of the joints, but some osteoarthritis starts setting in, and it actually stiffens up the joints. And there's some will actually feel like it improves. I'd say there's a sweet spot where it improves, and then becomes painful from the osteoarthritis afterwards. But that it can last longer for some people than others. as has been alluded to, there's a lot of joint instability, subluxations, dislocations, surgeries. Kneecaps are very common, shoulders, very, very common. Hips are very cited frequently, and the jaw. And the acquired or injury-based musculoskeletal pain is quite prevalent. So often prolotherapy, trigger points, acupuncture, physio are all cornerstones of treatment. However, often there is also some overlap with central sensitization, and fibromyalgia is very common. So a more widespread generalized pain as well. And these are just to help visualize the muscle. So the whole part of the muscle, tendons included, are riddled with connective tissue, and that's kind of part of the idea, showing the actin and the myosin and everything, and just showing that that's how the muscle fibers look. So going to the next one, the cardiovascular manifestations. So my biggest bane with this is that there's clearly not enough research. You can actually probably find almost all of the studies on the heart and adults and children with hEDS and other Ehlers-Danlos syndromes. There is mitral valve prolapse in only about 6% of hypermobile EDS patients, which is good ultimately. But there are things such as valvular leaking, valvular problems, which makes sense because it's made out of really stretchy material. They're present, but not really monitored, as well as maybe a good idea to do that. And I'm not quite sure the reason, but the main reason I have is, or that I can use to explain it, is that there's really only one literal study that I have found so far where people go from, the subjects ranged from 12 to 60, and that was the highest age that they tested people to. So if these valvular problems are going to arise, usually it will happen above the age of 60. So I do recommend people get echoes regularly. There are other ones that are not as common, but have been recorded. So dilation of various parts, various vessels around the heart. The one that's the most common that we look for is the aortic root, the part of the aorta that comes right off the heart. Again, since the only study goes to 60, it's not helpful, but 13% did have dilation of one of these vessels. So again, this is why I usually advocate for echocardiograms regularly. And so other findings, they're not quantified very well, but basically long and the short of it is that there are some cardiac symptoms involved. Now this is where we get cardiovascular mixed with neurological somewhat. POTS is super duper common. So most of the time you will end up with cardiac testing, because of palpitations due to POTS. POTS is a postural orthostatic tachycardia syndrome. So if you're standing, go from lying to standing, and your heart rate rises by more than 30 beats per minute within the first 10 minutes of standing, then you have a positive 10-minute standing test, and that is positive for POTS or dysautonomia. And the way to think of it is dysregulation of the autonomic system, which means dysregulation of essentially your fight and flight centers in a very generalized fashion. Again, multiple systems would be involved because multiple systems are involved in your fight and flight. A lot of lifestyle options can significantly improve symptoms, increasing daily water to at least 2 to 3 liters per day, increasing salt 6 to 10, and some I've seen ranges of 4 to 12 grams per day. It's quite a lot of salt. Some people do intravenous saline. Not a big fan of that because often the veins are quite delicate. So if you blow your veins doing intravenous saline, which if you're there, that's it. But if it's more elective, then by the time you might need to be hospitalized or something, your veins may be compromised. But compression garments, if they can be tolerated, the skin will let you, and then regular movement and exercise can be somewhat helpful. There are a lot of pharmacological options. I won't go through all of them, but we've tried many with many people. And then early varicose veins are common in every form of Ehlers-Danlos and arguably every form of hypermobility. Compression socks are good for those too. So sometimes you get a 2-for-1 on those. Now I'll get to more of them. I do see hypermobile patients with central sensitization symptoms. It's a team sport, so I do ask Dr. Arsenault, Rick, for help on that. But yes, most hypermobile patients have some central sensitization, so I wouldn't see very many if I don't see both. Is pain with hEDS increases when ages? That is very person to person. As I cited, sometimes in the stiffening phase, it actually improves. And sometimes as we go through the journey, you actually do find measures that improve one's pain. So that's very person to person, but from childhood to adulthood, definitely, yes. With MyCare, yes, on MyCare, you do need to call to ask to book with me. So that might help answer that question if anyone else was thinking that you need to call the support line. And no GP referrals needed. Yes, we've been trying to get more availability on the TELUS one. Okay, so next question is trying MCAS medications for neck pain. Treating one's allergic side has a lot of benefits. I don't always promise that pain will improve with it, but there are a lot of people who find that there's a lot of benefits. And I suppose technically it is possible, but I don't usually promise that one. It does sometimes cause more stabilization in other symptoms that does help the pain be a bit more easy to manage. So in a roundabout way, maybe. There's a loaded question of best management strategies for hEDS. It is very person to person, but the main things that we're talking about today, like managing MCAS and POTS and the chronic pain and central sensitization of pain, both through interventional means and through the pharmacological means, those seem to be pretty common things that really help. Are people with hEDS more prone to snapping, tearing ligaments upon impact? I mean, maybe partially tearing. I don't see as much full tearing. It's not impossible, though. It really does depend on how much trauma is associated with it. But I don't know if it was more classic EDS. Yes, some of the Ehlers-Danlos symptoms are more common for that than others. For hypermobile, it's not impossible. It really depends on the impact, but it can happen because the joints themselves are not as stable. And hello. Yes, hypermobile is a very strongly associated, like it's an autosomal dominant. Hypermobile EDS is autosomal dominant. So often your children will have it, the generation above you will have it. They might not be diagnosed, but you might see the same symptoms or the same hypermobility. So yes, it is a heritable disease and it is dominant. So it's a 50-50 chance that your children also have it if you have children and you have it. Medically confirmed link between hEDS and HSD. Yes, we will talk about that later. They are mostly anecdotal confirmations, unfortunately, but I do think there are some studies that are ongoing, and I rarely meet someone with hEDS that doesn't at least have some form of neurodiversity. So I can say that experientially, and it is in the literature. Yes. Downsides to genetic testing in Canada, usually financial only. That's not quite true. technically, you do run the risk of over investigating. It really depends on the mindset. If you're happy with the idea that if you have hEDS, your genetic testing will come back negative, and as long as you are still satisfied the 2017 diagnostic criteria, then it kind of just is very settling. Like it can be good, and it really confirmed that. It's not fully necessary if you have absolutely none of the red flags. So due to that, I'd say, considering you can do it with a very specific panel, then probably not that bad. Full genome testing can be Pandora's box. So I have, that one's a bit more, you run the risk of that. Type of exercise that I recommend. I should probably leave that one to a physio. Core strengthening is never a bad idea, but the biggest part is pacing, is making sure you're pacing well. But anything that's low impact, swimming's amazing. Tai Chi is very helpful. Pilates is incredibly helpful. But on all of those, it's, especially with central sensitization, you can really overdo it very easily. Why is the skin soft and velvety? Is an excellent question. Due to the fact that we don't actually know which genetic locus it is, that would be tough to answer in a very specific way. But long and the short of it is that the skin is basically almost full, like there's a large quantity of collagen and connective tissue in the skin. Most of the, if we went back to the slide with all the genetic mutations, a lot of them are on the collagen genes. And so the reason that we use is that since the collagen is different, it results in very soft and velvety skin. And some people even say doughy. Most people don't like saying that their skin is doughy, so I stick with velvety, but it happens. Any particular physio familiar to assist? There are actually a lot of physios who are very familiar with hypermobility, maybe not all of them with the systemic side of EDS, but I'm starting to encourage many of them to list themselves on the EDS Society website, and hopefully they do. Okay, so I'm going to get back to the rest of them. I'm sorry, I haven't answered all the questions yet, but we will try. All right, so this may answer questions. Mast cell activation. So this is technically MCA, and a lot of the times I will be referring to it more as MCAS, mast cell activation syndrome. So mast cell activation is very commonly linked to all of the Ehlers-Danloses, and is very common with people who aren't necessarily hypermobile. It's linked to hypermobile EDS, hypermobile spectrum disorders, and POTS. So the best way to describe it is chronic inappropriate activation of mast cells. So not always having a good reason why they might be activated, but that they end up activating anyway. This applies to both IgE-mediated and non-IgE mediated activation. I will expand upon that, but the best way to think of it is mast cells, and in this case I said MC, are part of your immune system. So every part of you that is exposed to the external environment, skin, eyes, mouth, respiratory tracts, gut and bladder, and genitourinary in some cases, they all will have mast cells. So if multiple parts of your system have mast cells activated, you can get symptoms in all of those areas. And it has been associated with many different things. So IBS, both constipation and diarrhea subtypes, interstitial cystitis, it is associated with that, eczema, sinusitis, even vaginitis, and those sorts of things. So there's lots and lots of ways in which these are mixed conditions. It's not all mast cells, but that they may play a role in helping manage those. So it's a newer area that it's hard. Now, the ones that are more obvious are the skin symptoms. So hives are huge. Being dermatographia, that's if you can like write your name in your in your skin by scratching it, and then hives will pop up in the shape of your name. Or a picture. Some people go with a picture. Flushing is a big part of it. Headaches, sometimes brain fog. And the most severe form of mast cell activation is anaphylaxis. Some people, unfortunately, will get anaphylaxis if it gets too flared. These are the coexisting conditions that a bit more broadly have been associated with mast cell activation. So I think that that's hopefully very validating for a lot of people. And then this is what I mean when I say there's IgE and non-IgE mediated. So that is supposed to be a mast cell. And if you have chronic activation of your mast cells, there are things like the triggers can be specific, and that's the allergens, that's the IgE mediated ones. But then there can be non-specific ones. So temperature extremes. Anyone who has had literally hives due to any of the above. It's too hot, you get hives. It's too cold, you get hives. Sunlight, you get hives. You get stressed, you get hives. And then pressure, that's the dermatography I was talking about, is like too much pressure, and you'll also get hives. So those are examples of how non-specific things can also trigger your mast cells. Can be quite frustrating. And anti-TPO is associated with that. So some thyroid. So we do see, I have seen, even though it's not in the literature, but I have seen a lot of people with hypothyroid. And again, it's not in the literature, but I have seen a lot of synthroid in my travels with hypermobility. And anti-TPO is associated with the thyroid. Apologies. So again, I put this here just so that people can, the graphic there, so people can refer back to it, but the testing is very limited. Most of the time, the best way to test it is honestly just to treat it and see what goes away. But if you choose to try and test it, usually they look at the serum tryptase, and you're supposed to try and find a baseline, which is very difficult to do without treating it, baseline when the mast cells are not activated, and then another tryptase when the cells are activated. It's very easy when you're getting anaphylaxis, because the tryptase will be very high. But if you get mast cell activation where you don't get anaphylaxis, sometimes it can be very hard to do this. And that's why it's only positive in about 1/3 of cases. Some people will order things like a 24-hour urine histamine. It's more, like at least you catch about 56% of people. And then you can do urine prostaglandins. Ideally, you can do all three. Not a lot of allergists in BC I've found will do all of it. But so it's important to note that even if you do not get a positive test on all of these things, it doesn't mean you don't have some form of mast cell activation. It's also important to know a lot of allergists in BC don't like the term mast cell activation syndrome unless you're referring to anaphylaxis. So just as a bit of like a specialist coaching point, if you are seeing an allergist, I guess avoid the term mast cell activation unless they bring it up first, but I've noticed a bit of a shift of mentality in that one. I treat people for mast cell activation once I find out they have hives or skin problems like eczema that have histamine associated with it. And when people have a reduction in symptoms, it's quite it's almost hard to get people to agree to stop taking their histamine blockers if they do respond. So it's quite simple, essentially, and very, very safe. So the histamine number 1 blockers, you have 4 histamine receptors. The histamine number 1 blockers, everyone already kind of knows them: Reactin, Arius, Claritin, Benadryl, etc. Usually I like the 24-hour ones, and I use urticarial doses, or doses for hives, which is 4 times the over-the-counter dose. And I combine it with an H2 blocker, which is usually it targets your stomach mostly. So that's usually Zantac or ranitidine, famotidine or Pepcid, or cimetidine. I don't use cimetidine as much. It's usually either Zantac or famotidine. You can add cromulin. You can use montelukast, low histamine diets, and there's more. Since then, ketotifen has come out more, and there's more and more things. Low histamine diets, I don't usually recommend this as a pure elimination diet because it's highly restrictive, but more of a proportion, like 20% of moderate to high histamine kind of foods or products. And then if you can get 80 to 60% of low, you probably have a lot better symptoms. And they're also coming out with more natural things that might decrease histamine levels. So it's a brave new world when it comes to MCAS. Okay, back to questions. Are people with hEDS at higher risk for arthritis? It's an excellent question. In some joints, yes. The thumbs for sure, depending on what you do. So I've had some people who like a lot of people who type all the time or are play a lot of instruments, things where you do a lot of things with your hands, heavy loads, then yes, you would be at a higher risk for that. So in the major joints, again, it really depends. If you do a lot of high impact activities, yes. But some people who do things like swimming and whatnot, lower intensity and exercises with low impact, you can preserve the joints quite well. The next one, shoulder joints. Oh yes, they are. Shoulder joints are, most of the stability comes from muscles and ligaments. So they're a slow rehabbing joint in that you have to build your entire rotator cuff to help rebuild those. The type of physio I would recommend, I mean, most physios are getting really good at shoulders because of the phones. Everyone's on a phone or a screen, so they're all getting very good at shoulders. So probably any of them, but many people will wear a shoulder brace while sleeping, and many people will wear shoulder braces throughout the day for their screen work. And if they're sitting, frequent position change is very helpful. You can, with the shoulder brace, a lot of times what I like to do, body braids are really good because they basically don't brace too hard. Like they don't replace your muscles. They're expensive, but they're very good that way. They just tell you when you're starting to slouch. They give you the skin feedback so that when because a lot of people with hEDS can't feel when they're slouching because they can't feel their position with their body. So you may find someone like almost fully hunched over before they realize that they've been slouching for 2 hours. So the shoulder brace is good at giving you that proprioception, or that sense of where you are in your body, if you do it with like about 2 fingers of space, so that you still have to do all the work in terms of all the stabilizing work with your muscles, but that if you do start slouching, that it gives you that reminder and you go back. Most physios and chiros are very, very good. I do like acupuncture as well, because sometimes it's not as activating for the fibro or the CFS, because it's just so, IMS can be very triggering. I can be diagnosed or cared for by a GP or as a specialist. Well, I mean, I'm a GP, so you can be diagnosed by a GP if they're comfortable with it. Many GPs are not. So I diagnose it. Some physiatrists and rheumatologists will diagnose as well. But most of the time it is done by a specialist. Yes, other than, I guess, me. Yes. Are facial features like attached lobes, hollow cheeks, thin lip, all features of EDS or just vascular EDS? Well, it is a difficult question. There are definitely features of vascular EDS and other genetic conditions. But the reason why I'm hesitating is because hypermobile EDS is so common that we haven't actually found the most common. There aren't as many super common facial features. We call them dysmorphias, but that's not a very lovely word. But there aren't as many specific facial features that would help in diagnosing hEDS, because it's actually very, very widespread. So you get too large of a variety of facial features with hEDS. It's possible. is all I'll say, is that you can have those features with hEDS, but you might have other features as well. So it's more consistent with vascular EDS is a better way to put it. Any recommendations on exercise fitness routines? Yeah, I guess I kind of already answered that one, but pacing is the most important thing with that one, and not being afraid to use a brace while you're doing it. Yes, very good question. How are people with hEDS at higher risk for long COVID? So kind of everything I said, but we will be getting to that a bit more. People with hEDS are more prone to central sensitization syndromes. And by that, they're more prone to long COVID, but there's a lot going on there. Like COVID also will trigger your MCAS. It'll make the POTS way worse with all the palpitations. Yeah, it's just kind of like in every way that it affects your system. It makes you more likely to get long COVID. Hypermobility and fibromobility, yeah. Proprioceptions. Oh yes. So yes, this person basically asked, with hypermobility, not necessarily diagnosed with hEDS, but hypermobility and fibro together, what about other systemic issues? And I guess when I said that hypermobility spectrum disorders, you can have very similar features as hEDS, so I would treat them similarly. You might not have the same things that happen in hEDS. Most likely you have fewer things, but that one you just kind of have to go by a case-by-case basis. If you're not getting GI symptoms, or your dentist has no problem freezing your mouth or things like that, then you probably won't get any of those like resistance to anesthesia in that. But again, with hEDS, it's so wide, some people with hypermobile EDS don't have to worry about those things either, lucky. But yeah. Okay, I'm gonna keep going. So just in case this answers some of the questions, but psychological. So this kind of refers to what an earlier question. So anxiety is common in all the hypermobility spectrum disorders, probably secondary to some of the literal pain, but anxiety is very common. Panic disorders, and it's almost, as you can see, it's over 2/3 of the patients for some of them. Mood disorders are very common. Is it situational due to working with the different things that are going on, or is it something that is inherent? We don't know, but some will say up to 42%. Others, again, if it's situational, it probably is a bit higher. There can be addictions associated because people will try to self-medicate with the pain, but I find that treatment's really helpful for this, because like me treating hEDS, because ironically alcohol flares all the pain up so much worse, that most people, once they know that, actually avoid that whole scenario, thankfully. But the neurodevelopmental disorders is where I think the real research needs to happen. So depending on the study, there are people saying they definitely see some more increase in autism spectrum disorders, attention deficit and hyperactivity disorder. The studies are often very, very small, but there's a positive association for sure. And developmental coordination disorder, and some people consider that kind of like increased clumsiness, or not having as much physical coordination. And a lot of these neurodevelopmental or neurocognitive disorders have overlap within themselves. So you can have a mix of these. Eating disorders, now that's mixed, because a lot of people have GI problems with hEDS or other Ehlers-Danloses, or other hypermobile disorders. And there's almost a fear of eating as opposed to actual pure anorexia nervosa. Cognitive dysfunction, a lot of brain fog, based on everything we just talked about. That's not surprising. Everything we've talked about so far causes brain fog. And due to chronic pain, there's often also a lot of sleeping disorders, but a lot of sleeping disorders even without it. So I like this graphic because it helps show, we've got all the physical ones, we've got the somatosensory, got everything happening all at once, and then in the middle, of course, at the end of all of it, there will be, it's hard not to worry. Anxiety is the increase of fight or flight drive and worry. And you may also have dysautonomia, which dysregulates your fight or flight. So anxiety, that's why it makes a lot of sense that anxiety would be one of the most common things that presents in a psychological fashion, because they all just intersect right there. And this is what I was referring to when it comes to the cycle of eating disorders within hypermobility, especially with GI disorders, is between the allergies and the intolerances. You may restrict your diet to try and help your symptoms. You may over-restrict, and then absorption can be affected, and literal volume of food can be affected, obviously. Difficulty, painful eating, reflux. You stop eating because every time you eat, it hurts. So it's not often associated with somebody's sense or body dysmorphia or whatnot. It can often just be because you almost develop a phobia of eating. So that's important to acknowledge that it's not the most typical form of an eating disorder that you might find in Ehlers-Danlos or hypermobility in general, or even if someone doesn't have it, if someone has IBS or any of these things, they can go through all these symptoms as well. And the final one that I'm going to focus on is central sensitization. I couldn't do all the systems because there's just too many, but with central sensitization and with all we kind of covered, we know that hEDS has different neurological sensations, literally. It's also important, so there's a decreased ability to sense one's position or posture within one's body, but in a different way. A lot of people with hEDS and hypermobility spectrum disorders in general will also perceive pain differently. So it is hypothesized, and there are some beginnings of studies who are trying to see and testing hypermobile people for hyperalgesia, being very, things that would feel not painful to other people will feel painful to someone who has hyperalgesia, and that with this there's a increase of perception of pain within the brain. So as you saw with a lot of the conditions that are associated with mast cell, they're also associated with chronic central sensitization, including long COVID, as a very, very good question at the beginning that we already answered. So, and then when you look at all the other things we were talking about, POTS, dysautonomia, MCAS, and the psychological side of it, and you put them all together, it's really not a big surprise. It's really not a big surprise that these conditions all go together. So that's the conclusion. Those are the ones I focused on because they usually tend to be the most helpful, to be honest. It's quite a remarkable condition when you think about it. It involves all of the systems, really. If you over compartmentalize it, you kind of miss the boat. But so you need to see the whole body in this kind of condition. And if you don't, you can easily get lost, as I said. If you find the diagnosis very early and you start getting certain things in place, you really, really can avoid a lot of quite literal pain, and a lot of problems. You adjust super early to how like even the choices of exercise that you'd use, and foods and so on and so forth. There's many treatments, but my final point, and probably the most important one, is that treatment and management of Ehlers-Danlos of any kind, especially hypermobile, like it's lifelong. It's a marathon. It's not a race, or if you want to call it a race, it's like the ultra marathon. So it's So it is lifelong, and but there are things you can do to manage the symptoms. So just go back to that. Yeah, I just like some empowering slides near the end because we covered a lot of very heavy things. Most important part is that every day we're still here trying. So I hope that's good. And these are some resources, but I'm going to go back to the questions while we're here. There's a person asking about vertigo and optic nerves. Could hEDS be involved? I'm not sure if there was also POTS involved or other things, then I wouldn't rule it out, but I'd have to see the case specifically, I'm afraid, for that to have a good answer for that one. I wouldn't rule it out, I guess is a good way to put it. If your Biden score is too low and you have a high number of multisystemic symptoms, can you still be diagnosed? Depending on how old you are, the Biden, like for example, if you're over 50, the Biden score only needs to be 4 out of 9. And if you get 3 out of 9 and you used to be able to do some of those things historically, that would still count. But I have met people with chronic pain, MCAS, POTS, like kind of almost everything, and they don't have hypermobility. You still do the same treatments in a way to try and see how much benefit each one gets. I still trial. I would still try all the same treatments to make sure. If you don't have the diagnosis, but you have all the other ones, then you'd still treat all the other ones and hopefully get improvement the same way. But I would evaluate that, because if you're over 50 and you had 3 out of 9, but you historically could do at least 2 out of the 5 things that are on the diagnostic list, then you are 4 out of 9, and then you would be positive. So again, it's a misnomer. Some people really think you have to be 9 out of 9 to be positive, and you don't. What would you recommend if the most significant issue is neck pain and subluxing and angst? That's loaded. I'm a big fan of trigger points in prolo and in interventional pain measures, as long as they don't overtreat you and give you a central sensitization flare. It will be a process, at least 6 to 8 weeks before you'll really know whether it was improved or not. But bracing is important in the injury phase of it until the muscles are stabilized, because the muscle weaknesses, your muscles are your stabilizers with hypermobility. So that's one of the big reasons why recovery can be difficult, is because you have to build up the muscles to be the stabilization. I think I don't know if the slides will be emailed. Chiropractic uses a different definition for dislocation. I mean, dislocation is more severe. It's the joint being fully out of the socket, the bone being fully out of the joint. Subluxation I see a lot, so that's when it's a partial dislocation. So that's kind of what I mean. Dislocation is full. Say it's the head of the humerus being fully out or forward, usually out of the shoulder joint. But a subluxation, it wouldn't be fully out, but it would definitely be slipping partially out. So those are what I mean with those. Can the stiffening phase happen early? Yes, it can. I've definitely seen early osteoarthritis in some people, often with a lot more contact sports and things like that. But usually when it's ME, CFS, and fibro, that's still probably a lot of the pain. And a lot of muscles, especially if your ligaments are so stretchy that your muscles are actually less stretchy than your ligaments. Traditional things that enhance flexibility, such as yoga and whatnot, they don't work, because it's like trying to stretch a stake between 2 bungee cords. The bungee cords will stretch more than the stake will. So a lot of times you do need things like trigger points or acupuncture or IMS to loosen up the muscles, because they won't loosen with just stretching alone. Your ligaments will, but they will do it more than your muscle will? That's very similar question. And so restless legs, possibly, especially if there's iron deficiency with it. Don't know that I've read something specific, but I wouldn't rule it out. But I don't know if it's more, if restless legs are specifically associated with EDS, or if it's then any condition can go with hEDS as well at the same time. Anyone who is I'd say anyone who considers themselves double jointed, and especially is heard from other physios. The question is, like, when is it worth pursuing a hypermobile or an EDS diagnosis? Let's just say the person who asked, I'd say there's lots of joint instability discussed and skin, many things going on there. So I'd say that person should probably consider being assessed for EDS. Yes. All of the criteria is available online through the EDS Society website, the first one. So everyone's, if you go through the 2017 criteria, then and you find you have a lot of features, then I definitely pursue it. Association between EDS and cellulite, I don't know, but lymphedema can happen with EDS. So if it's associated with that, then yes. Yes, no, it's a few people have commented. We are really trying to increase availability. There's been a lot going on in more than one clinic with me right now, which is not within my control, unfortunately. So I am definitely working on different ways to improve availability, and I am sorry about that. Yeah, it's I won't bore you with the details, but it's been out of my control. So working on making that better for sure. And I'm working on making availability for referrals for me better. Although on TELUS MyCare, you don't need a referral. Bone disease. Yes. So osteoarthritis is more common. Early onset osteoporosis, I don't actually see that as commonly. Usually the bone strength is quite good. Usually it's other genetic factors or other risk factors. So generally speaking, osteoporosis happens more commonly with people who are of European or Asian descent, not as much weight-bearing activity, and if there's a family history of it, among many other things. So if all of those things happened on top of hEDS, then yes, definitely. But if none of those things happened with hEDS, your bones would still probably be quite strong. I am able to diagnose. I do not need to refer. If we're doing it virtually, it is very helpful to have a Biden score from a physio or someone like that. Does POTS get worse between the age 20 and 40? Does really depend on the person, but a lot of people get more symptomatic from POTS somewhere between their 20s to 40s. Like, a lot of times the symptoms will rise then, if it doesn't arise earlier. So I guess in a way, yes, but you can also implement the lifestyle things to improve it. I'm not sure if we're going to get through all of the different questions, so I'm really sorry if we don't, but I'm going to try and keep firing through them. Yeah, higher risk of stroke, thankfully no, there shouldn't be. And I think that was there was more of a comment than a question, so I'll leave that one. Yes. Okay, so there seems to be this like misnomer that you can see family doctors with special interests without needing without having to give up your family doctor. I don't advise people to transfer their care to me on TELUS MyCare, and some GPs seem to have that that perception for some reason. So I'd be considered a family doctor with a special interest in hypermobility, genetic hypermobility causes, And you can do a referral for that. It's just through MyCare, you don't need one. So I see people with or without referrals all the time. And I do put it very specifically down that I'm specifically there to assess the hypermobility. So if there is, so most GPs are okay with that. I haven't had a lot of problems, but it's not the first time someone's asked if they can see me for hypermobility without having to kind of give up their family doctor. And my answer is, please don't give up your family doctor. And yes, you can see me because it's for my special interest, not for taking over primary care. Over the age of 50, how often do you recommend irregular echoes? If you have no symptoms whatsoever, most of us agree that it's probably around at least 2 to 5 years if there's no symptoms. But if you are getting palpitations, lightheadedness, POTS, and they're not controlled, and then you usually get more regular echoes, like once a year or every 2 years, depending on what's found. I can? Okay, sorry guys. Someone just told me if I click it before, you can see the questions. Okay, I'll do that. Thank you. Thank you very much. When getting an echo, yes, cardiologists would be looking for mitral valve prolapse and aortic root dilatation. They should know that, to be honest. Many hypermobile joints. The locking, yes, joint locking. Braces are very, very good for joint locking. It does depend on the joint. It is very, very painful. Braces are usually the best for that. And I'm really sorry. Depending on the joint that you're experiencing, they might be able to do cortisone injections. This individual has said confused about the definition of velvety. Many people get confused about that. We get that question a lot. I don't know how else to describe it, but the skin literally feels like velvet. I usually say on the, we call it the volar surface, but on the inside of your forearm, if you feel it and it feels kind of like velvet, that is velvety skin. That's honestly it. It's not very sophisticated that way, but it feels like velvet. Answer first. Skin biopsy showing specific connective tissue disease. They haven't been doing skin biopsies as frequently. With hEDS, I still like going through the 2017 criteria, but it is curious. Yes. How can we book a consult? So from what I've been told, tell us MyCare. Again, they approved some extra time for me to see more people. So I'm hoping that that's enough for now. You call and request to book, like you have to call the support line and request to book a hypermobile consult with me. And they only allow booking out a certain amount of time. I think it's about 4 weeks at a time. But that apparently they release it every 1 or 2 weeks. And if you call back and you call for one of those spots, that they will try to get you fit into them. And so I'm sorry. Sorry that has been, a lot of people have said it's proven difficult. This person has Sjogren's. Tissue fragility can be an EDS thing. I'm not sure if it's specific to the mouth or gum tissue, but there are other Ehlers-Danloses that are specific to mouth and gum tissues. In your case, it probably is the Sjogren's, but you can ask your dentist because they're actually very good at if you have the dental EDS. Best mast cell stabilizer. Oh, well, that's a wonderful question. I don't know yet, but a lot of people have found that the over-the-counter antihistamines at the urticarial doses are incredibly, incredibly safe and to do long-term. In terms of mast, cromulin's really good, ketophanin's really good. Really whatever works is what it comes down to. All of them are designed for long-term, thankfully. Yes, there are lots. I have been using more ketotifen, and the main problem with a lot of the mast cell deactivators nowadays is actually getting them covered. So that part's that's all, that part's frustrating. And yes, hello peoples. Is it a bad sign if the joints start to clunk and crack? Well, I would definitely check in with physio. I don't know if it would be a bad sign, but I would check with physio. Sometimes it is actually a spasm muscle that's rubbing over your joint. But it's a lot of people with EDS, their joints cracked since they were children. So one person came in and that was their clue, that they said that when they walk, it sounds like snap, crackle, pop. And so that was their clue, but they've had that lifelong. So it's not always necessarily a bad sign, but I would check with physio if it's any new change, or your doctor if they're open to it. When I take H1 blockers at a normal dose, I cannot sleep. Yes, I've actually had that before. So it is a bit curious. Often I will ask people to try a different type of H1 blocker and see if that one, so one person was sensitive to Reactin, and they'd only take it in the morning because if they took it in the evening, they couldn't sleep. So I usually would give something that would be more sedating at night, and then they can keep taking the over-the-counter one in the morning. So I used hydroxyzine at night or Benadryl at night, and then Reactin in the morning because it was not sedating. But there's one or two people who said Benadryl actually kept them up, so you couldn't use that one. Yes, there's are women with hEDS more risk for endometriosis? I'd say yes, definitely, but you also get pelvic pain. So until you actually get the exploratory, you don't actually always know if it's pelvic pain and outlet syndrome and so on and so forth, or if it's endometriosis. But I've seen a lot of women with hEDS and endometriosis. And frozen shoulder related to stiffening of hEDS. I see more of that with, like, if there's hypothyroid. I'd say it's more associated with hypothyroid, but I've seen a lot of hypothyroid with hEDS as well. So maybe in an indirect way, but I wouldn't rule it out. I don't know if there's enough studies for me to say that it's not associated with hEDS. I mentioned the body braid. Yeah, the body braid is it looks exactly like it sounds. It's kind of like a braid kind of bracelet made out of, I guess you could describe it almost as seatbelt material. It's literally, if you Google body braid, you can find it. It's not cheap, but it's very helpful for a lot of people. And I think the EDS website has links to the body braid itself. They love that. Sleeping tips for joint stabilization. Honestly, there are people who sleep with their braces on, especially the shoulders, because they collapse right in there. Pardon me. So that's probably my best tip. But the pillows for maternity, like the big C-shaped pillows, some people really love those. Some people hate them. But so depending on how your sensory situation is, if you're very, very sensitive to tactile input, I would not recommend that. But if you kind of love the coziness of a big body pillow, then I'd recommend that. Or braces. Some more MCAS questions. So there's still lots. I'm not sure if I'll be able to answer all the questions, but I'll just keep going. When I take the minimum dose, yeah. Okay, so that's the same. I'd switch the H1 blocker that you're using. So symptoms like brain fog, headaches, weakness, and all that, when there's big changes in temperature, that's usually the barometric pressure, unfortunately. And it can be related to sinuses and whatnot, or it can be related to swelling in the head or in the muscles and so on and so forth. It's usually more the sinuses. But yeah, you can definitely get flares with changes in air pressure and season changes. Tongue and lip tie common in EDS. I've seen it. I don't know exactly the rates of how common it is, but yeah, I have seen lip and tongue ties and lack of frenulums actually also. Bifurcated uvula, and yes, bifurcated uvula is one of the reasons why I would ask you to see genetics. but it's usually bifid uvula and associated with like your eyes being very far apart. They call it hypertelorism, which you can find out from your optometrist, over 6.6 centimeters to be exact. So if your eyes are more than if your interpupillary distance is more than 6.6 centimeters apart, and you have a bifid uvula, then you should definitely see genetics, and you're hypermobile. Tips with chronic pain. That is very case to case, but and Dr. Arsenault is the expert on that one in some ways more than me, but I do really love PEA, and I am a big fan of low dose naltrexone and ones that you can take all the time, and it sometimes does really help. And sometimes managing any of the other systemic things that are happening will really help with the chronic pain. And it really does depend which pharmaceutical people are reluctant to prescribe. I don't find low dose naltrexone to be a problem because it's really, really low dose, but yeah, there's lots of options for pain, thankfully. Nausea after eating. Yeah, a lot of people have a lot of reflux because the esophagus and sphincters and everything, they're just very, very flexible. Can central sensitization go away? I might leave that one to Dr. Arsenault. I don't know the answer, but I know that you can rehab it very, very well. But it's very case to case. So I'm sorry, I don't have an answer. Okay. I'm not sure. Again, when it comes, someone's asking if they could see me. Essentially right now, the only way I can accept more people is through MyCare. It's one of the clinics I was working at closed, so it's just a whole thing. Yeah, so I think we're 5 minutes away from 4:30. Dr. Arsenault, do we have more time or to keep answering questions or not?
Yeah, we started a couple minutes late, so we could probably go until 4:33 or 4:34.
Okay. All right. All right, so I'll just keep doing it. Can treating mast cell with hypersensitivity help with hypersensitivity? I think the jury's out on that, but it definitely doesn't hurt. And hello. It helps a lot to make sure the mast cells are treated, especially if they're flaring really badly, and especially if there is any anaphylaxis, of course. Also for safety. But I have found with some people that especially if they have sinus, if nasal and respiratory is part of it, that it really helps with the headaches. So it is somewhat dependent on what is the main thing. Anyone who does have mast cell stabilization or activation, lack of stabilization in their guts and in the bladder, sometimes the pain from that is alleviated somewhat. So I do think it helps in different layers of pain. Whether it helps the musculoskeletal pain or not, I think the jury is out on that one. I wouldn't bank on it. Oh, thank you. I'm glad you enjoyed the presentation. Taking collagen. If you have dietary restrictions to the point where you do not get adequate collagen, then supplementing your collagen is not a bad idea. But it's so prevalent in many, many different types of food that often people are taking adequate collagen through diet. It doesn't hurt, but I don't know if it really helps unless you're deficient in collagen already. And you have to break down all the collagen you eat and you reform it in your own way. So it's not going to give you a different form of collagen, if that helps. Creams. Yes, creams for pain. I do like creams for pain, as long as you are not allergic to them. So sometimes some people cannot use creams for pain because they will get a rash from them. But if you do not get that, definitely like using creams for pain, yes. Diagnosed with EDS. Oh, I don't think hEDS is a reason to consider not having children, mainly because there's such a broad spectrum of symptoms with hEDS. So some people have hEDS and are very, very asymptomatic. They pretty much just it's lovely. And many of us are jealous of them. But you know, they exercise regularly, they have lovely diets, not always, but some people are just really not very symptomatic. So you never know which one they're going to get. There are some people with the hypermobility who can't imagine being pregnant though. And so I'd say that's a different thing, is that if you have enough joint instability, that any extra hormonal reason for your joints to get any more unstable is quite literally terrifying, then I'd say maybe don't put yourself through pregnancy. But there are other people who with hypermobility have, you know, adopted children or helped with the foster care system. So it's not like it's off the table, even if you choose not to get pregnant. But I wouldn't specifically say don't have kids if you have hEDS, because the children might be perfectly fine. Choosing activities, yes, for kids who might have hEDS. So children generally recover incredibly well. So a lot of times you don't really have to restrict them too heavily, maybe not rugby or heavily contact sports, because rugby doesn't have a lot of equipment. A lot of the other sports that have contact are now ramping up their equipment quite heavily, but I'd still say like anything that puts you at increased risk for concussion, which I'd say for any child, it's probably not the best idea. Core strengthening exercises, lower impact exercises. You also have to couple it with whatever the child is interested in. So it might be difficult. If they want to do what they do, just make sure they have a very good physio who's helping them with it. And if it is going to be not dance so much, but like gymnastics, just make sure that the coach is aware that they're hypermobile and encourages them not to overstrengthen, not to overstretch, and more to focus on strengthening. Yeah, hEDS and all EDSs have major bruising, and you do not have to have VEDS to have a lot of bruising, like a lot of bruises you don't even know where they come from. Lots of bruising. I guess I was really passionate about that. Can injuries worsen or exacerbate hEDS? They worsen the symptoms, but the hEDS was there since you were born, so no. But they definitely worsen the symptoms, but the way your collagen is will not change from acquired things, generally speaking. Oh, yes, thank you. You're welcome. The referrals, yes, it is all through MyCare right now. Clinic that I was previously accepting referrals through has closed, so that's the reason why. But yes, hopefully I get to see you too. Scarring, yes, and oh yes, hydrodissection. So yes, Dr. Yuan in White Oak Clinic in Burnaby does the hydrodissections that were brought up, and yes, thankfully some people have found them very helpful. How long have I been associated? I'd say probably around this time last year. That's probably the closest. How long have I been familiar with ME/CFS? I think that's just one of those other things I kind of take for granted. I mean, it was around when I was medically growing up or training, and it was just one of those ones that always kind of made sense. I would joke in residency that residency causes ME/CFS, but it might not have been the best joke. Am I aware between, so I guess, I don't know if yeah, so I've mainly been focusing on hypermobility for, I've known about it forever, medically speaking. I've mainly been focusing on it for the last year or so. Am I aware between hEDS and elevated CK levels? I have definitely seen that, yes. There's multiple reasons why you could have elevated creatine kinase levels. I would encourage people to make sure all the other investigations for elevated CK levels have been completed before saying it is purely due to EDS. I guess it's the best way to explain that one. Yes, so
I think we're done. Thank you so much, Dr. Ma. Another great presentation. And we'll have you back again because I'm sure there's lots more questions. But have a great week, everybody. Also, as a reminder, yes, the slides will be emailed to you. And those of you who are asking about some specifics about exercise, Judith Orban, who is a physiotherapist, occupational therapist with expertise in this area, is doing a presentation on April 26th at 3 p.m. Bye-bye, everybody.